My name is Johannes Wolf. I'm recording these teaching videos to support clinical cancer research, helping colleagues that come into the world of clinical trials to educate themselves on their own time. If you are a patient, you may not want to watch this. Please accept my apology. Scientific numbers and methods can appear heartless, disrespectful. Be assured they are not. We plan to make videos also for patients with more appropriate respect there. In previous videos, we have covered time to event endpoints and the concept of Kaplan Meier curves. This video is about how to read these curves and will explain the stair shape of progression-free survival curves. We entitled this video Kaplan Meier Curves, How to Read Them. It will have examples of real Kaplan Meier curves from the literature, and therefore we will need some medical background. We'll talk about choroid plexus tumors, what that is, and then about event-free survival curves of choroid plexus tumors to explain median event-free survival times and 1-year event-free survival rates. We'll talk about prostate cancer, the basics of that, and then use data to explain the stair shape of progression-free survival curves, the sharp and the soft steps. It's very interesting. And finally, we'll talk about the final drop of Kaplan Meier curves and that they mean very little. This is the background of choroid plexus tumors. Choroid plexus tumors are the most common brain tumors in neonates. They're very rare, but in neonates, newborn babies, they are the most common type. They are symptomatic as hydrocephalus, water in the brain where it shouldn't be. In newborn babies, this typically shows as a large head, unless it's already known before they were born from ultrasound. This is how a MRI can look like. The white thing in here is the tumor. These two things on front are the eyes. The gray piece is brain. The black part is water, CSF, cerebral spinal fluid. That shouldn't be there, and it is there because the tumor blocks the pathway of it. Choroid plexus tumors are linked to a genetic syndrome called Li-Fraumeni syndrome, which is linked to P53. There are different degrees of malignancy, different levels of how bad they are. The lowest of those is called choroid plexus papilloma, and the highest is called choroid plexus carcinoma. The World Health Organization, WHO, gives this a grade 1 and this a grade 3. In between are the atypical choroid plexus papilloma. The more benign version of the tumor have a histological picture as it shows in the microscope that looks very much like a normal choroid plexus, that is a normal structure in the brain. When the tumor is diagnosed, the first thing that is typically to happen is a resection, surgery, and the degree of that resection, if it is successful, if it takes all the tumor out, is extremely important for prognosis, regardless what histology it is. In some of the tumors, chemotherapy and radiation can be given thereafter, and it can help. In general, it is better when the curve is further to the right, because that means that the events happened later, and it is better when the curve is higher, because that means there is a larger number of people without events. There are these check marks on top of the curve. Each of those check marks indicates a patient story that ends at that point without an event. So this check mark here means that about 8 years of observation. There was one patient that had 8 years of observation, and then the observation time ended, either because that was the time the whole study was analyzed or because data are lost, the patient was lost to follow up. The further those check marks are to the right, the more mature is the curve. So here in the APP, atypical choroid plexus papilloma curve, you see all these check marks far to the right. You can do the parallel here with median event-free survival. And the way to do this is you go on the y-axis, find the 50%, in this case it's 0.5 curve, and then you go down, and then you can read the median event-free survival for this diagnosis, choroid plexus carcinoma. And it's about 2.5 years. But what about the other two curves? They don't cross the 50% line. You cannot describe them with median event-free survival. Median event-free survival was not reached. There are other ways to describe the curve. This is one of them, the 10-year event-free survival rate. To read this, you start on the x-axis, go to the 10 years, go up until you hit the curve, go back to the left, and then read on the y-axis the 10-year event-free survival of choroid plexus papilloma. And you can do the same thing for the other curves, and then you have three numbers where you can compare the three diagnoses, and then you have a good way to describe, even without the figure, that this one is the worst, this one is in the middle, and this one is the best. Now, the trial that I referred to was called CPT-SIOP 2000, and it also had a chemotherapy question. Carboplatin 1 over cyclophosphamide, that's the carboplatin curve, that's the cyclophosphamide curve. Let's go to a different diagnosis. Prostate cancer. Prostate cancer is a story of old people. Biology is different. These tumors are hormone dependent. Cancer cells aren't dependent, don't listen to hormones. Prostate cancer is different. It has a particular biology and it grows faster when there is testosterone around, or even shrinks when there is no testosterone around. The symptom of prostate cancer are mainly urinary retention. This is because the prostate obstructs the urinary flow from the bladder. The diagnosis is PSA, that's a lab value, can be drawn from blood. MRI images show the shape of the tumor, and really the most important differential diagnosis is the benign prostate hypertrophy, and the best way to differentiate the two is the biopsy. First-line treatment in case of prostate cancer may be surgery or radiation, or watch and wait, because this tumor is extremely slow growing. Thereafter, there can be hormone deprivation therapy. That can be a surgical removal of the testicles, or there are medications that can do the same thing. Those are called androgen deprivation therapy, ADT. If that doesn't work, then there is a longer line of treatments. Those include various chemotherapeutic agents, other hormone therapy, PARP inhibition, immunotherapy. There's well over a dozen drugs approved for prostate cancer. Let's look at one of those. The most important information from the title, in my view, are the last two words, prostate cancer. That's the diagnosis we're treating here. The second one is the first word, darolutamide. And then in between, non-metastatic, castration-resistant. Prostate cancer is a hormone-dependent cancer, and it depends on androgen, testosterone, and dihydrotestosterone. Testosterone passes through the membrane without a receptor there. Intracellularly, it is changed by the enzyme 5-alpha reductase to dihydroxytestosterone, which binds to the intracellular androgen receptor, phosphorylates, binds to the DNA, and then has the effect on prostate cancer growth. The drug, darolutamide, inhibits this, stops it, blocks it from happening. This is the most important figure of the paper, in my opinion, the Kaplan Meier curve of the metastasis-free survival. Two curves, one for patients that received darolutamide and one for patients that received placebo. As you can easily see, the curve of patients receiving the drug is to the right and above of the others. That's how we want it. That is a good result. You see the median event-free survival or median metastasis-free survival here with the 50% coming down in this spot for placebo, and here for darolutamide, and the numbers are 40.4 and 18.4, so very different from each other. This is the result of the statistical testing. The p-value is one way to look at this. If this number is less than 0.05, we normally consider something statistically significant, and this number is a lot lower than 0.05. It is even less than 0.001. This result is statistically highly significant. You can also read the 1 year survival rate if you want more numbers, and you can do this with 1 year, 2 year, 3 year, and you can do it with the treatment curve and with the placebo curve, and you get to those numbers. The numbers all say the same thing. The 1 year metastasis-free survival rate with the drug was 83%, with placebo only 64%. However, you look at this curve, it is clearly a winner for the drug. Let's get a little bit more sophisticated with Kaplan Meier curves. This curve looks like stairs. This is a stair-shaped curve. And there are two types of steps, soft steps and sharp steps. The sharp steps come from the way how Kaplan Meier calculates. A step like this reflects one patient that had an event. The soft steps here have multiple patients. Why did all these patients here relapse at the same time? Did they all get metastases at the same time, at about 4 months after starting the treatment, and then again another set of patients get it at 8 months? Of course not. Of course not. The metastases occur anytime and they grow anytime. What we see here is the reflection of when we, as the medical society, can detect those metastases. And the way we do that is with imaging. In a clinical trials, the time points of imaging are pre-prescribed. So you basically see the first imaging was here at about 4 months. The next one was here at about 7 months. And every time some metastases are detected and the curve makes a little step down, just because all those steps are at the same time, it looks like a very big step. Those are the soft steps. So the soft steps come from imaging. The sharp steps are mathematical results of the Kaplan Meier estimate method. This is the overall survival curve that goes with it. You see also here that the drug curve is above the placebo curve as we wanted. You see that there are no soft steps in the overall survival curve because that's imaging independent. This only gives you an event when somebody dies, and the time of death is not dependent on imaging. But the sharp step does exist. And it even is very deep in the end of the curve. How come the drug curve ends below the placebo curve? Well, that is a bit of an artifact of the Kaplan Meier assumption. This large step reflects only one single patient of 955 patients that have started. The reason why it makes such a large step in the curve is because there are so few patients in observation. Down here you see the numbers. These numbers carry about the same information as the check marks, or here the circles on top of the curve. 955 patients started, but at the time point of that gigantic step, there are less than 8 patients in observation. Then the curve drops by 1/8 of the curve if 1 of 8 patients dies. What you got to learn from this is that this curve is still better than the other curve. You have to look at the beginning of the curve where the numbers are much larger. The end of the curve is relevant. It is an estimate. It is mathematically corrected estimate, but it means much less than the beginning where there are more patients in observation. This is a different study, but it is still a prostate cancer. Here, the addition of a chemotherapeutic agent, hormone therapy, was tested. And you see, this is the docetaxel arm, that is the chemotherapy arm. Underneath is the control without docetaxel. And the conclusion also here is that there was good evidence for the benefit of docetaxel over standard of care. And again, a p-value well below 0.005. But How can this curve be better than this curve when it ends lower? Now, that is again the final drop of the curve. In this case, the drop goes even down to 0, which means the patients with the one patient with the longest observation time had an event. That's when the curve goes lower. And it looks dramatic because it appears that the Kaplan Meier estimate estimates everybody to have passed away after 8.5 years. And it does. The Kaplan Meier estimate estimates that, but it only is an estimate. And it depends on how many patients are in observation. You see these numbers down here. They started with 320 patients, and here was only one left. So that part of the curve is in a way misleading. Here is the truth. This is why the docetaxel arm looks better and is better. So that's the end of the video. What have we covered today? We learned that the check marks on top of the curve or the numbers under the curve show how mature the data are. The further those check marks are to the right, the better is the curve. Median overall survival, median event-free survival can be given when the Kaplan Meier curve cuts through the 50% line, and it cannot be given if it stays above. But 1 year overall survival or event-free survival in the video can be given even when it stays above the curves. Progression-free survival curves or event-free survival curves can look like stairs, but those are artifacts. One part of the artifacts is mathematical. It gives you a sharp step, and it typically is in the end of the curve. The other one is smooth and comes from imaging. The final drop of a curve to 0 means very little. The most important piece of the curve is in the beginning. That's what you should use for comparing and judging a curve. And with this, I thank you very much for your attention and wish you a good day.